I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University in Canada, and I'm absolutely delighted to welcome Professor Gregg Fonarow, who is the Chief of Cardiology at UCLA, and Dr. Tariq Ahmad, Associate Professor of Medicine and Principal Investigator of the PROMPT-HF trial. Welcome.
Thank you.
We are here at ACC 2022 to discuss the exciting findings of the PROMPT-HF trial. And I am delighted to begin this conversation by asking Dr. Fonarow, who's been a thought leader and a researcher in this space, to place this trial in context of the patterns of utilization of guideline-directed medical therapy among our patients with heart failure. Could you give us an idea of what the uptake of medical therapies has been and whether those numbers have changed over time?
Sure. So despite our patients with heart failure with reduced ejection fraction facing substantial risk of hospitalization mortality and having a number of evidence-based guideline recommended therapies, we've seen in setting after setting how challenging it is to get these medications prescribed and fully implemented. So data back 20 years ago, 10 years ago, more recently, we've seen in a variety of settings, not just community practice settings, but also academic settings, large gaps in the use of therapies, including ACE inhibitor ARBs, beta blockers, and MRAs, where cost really is not an issue. There's been some improvement over time in RAS inhibitor blockers and beta blockers, but especially in the United States compared to other countries, large underuse of MRAs, and then newer medications like sacubitril valsartan and the newest class of drug, SGLT2 inhibitors, much larger gaps. And there's also substantial variations and disparities in use.
Why do you think those gaps exist? Can you give us an idea of what the evidence tells us about the possible reasons for underutilization of these therapies?
Yeah, it's really complex, but a lot of it has to do with so much of routine clinical practice is not necessarily driven by protocols, that there's not clinical decision support at the point of care that's being provided, that it's often medicine by memory. They're not necessarily alignment of incentives. And there's very strong clinical inertia, this idea of I'll leave it to the next visit, where the patient hospitalized will leave it for an outpatient basis. And then in that busy visit, it gets overlooked. And so there's a lot of complex reasons involved, but we've seen in setting after setting, these exist so powerfully. And that's just talking about the use of medications. Up titration also is where we see often many of these patients, even though they could tolerate higher doses or haven't been tried, have room on their blood pressure and heart rate. There's not the attempt to up titrate the medication.
Right, and then there's the issue of comorbidities and the complexities that those bring, and perhaps there's a role for electronic alerts and algorithms of care that could facilitate decision-making around implementation and up titration of therapies. And to that point, I'm going to ask you, Dr. Ahmad, what you tried to achieve with this trial.
Absolutely. Thank you, Harriette. And what Dr. Fonarow says is so important. Everyone should rewind and listen to that several times because it's such an important point. And in part, his tweets and what he's written inspired this because you would see patients, for example, if you have a patient who post a heart attack and they get a stent and if they get sent home without Plavix, for example, and they get readmitted, that's a big deal. Mm-hmm. But I would see over and over again patients being admitted with heart failure who had not been started on these medications that are life-saving, and nothing would happen, right? It's people say it's just part of usual care, and there's really nothing that made clinicians who see these patients take responsibility for putting them on these guideline-directed medical therapies. So we had set up a registry across our healthcare system, which is completely integrated, and we it's live, so it gets updated every day. and we found that, of the 28,000 heart failure patients that we have, we had about 6,000 or 7,000 with HFrEF, and we could see what medications they were on and what doses were on. It was pretty clear that there were massive gaps in prescription of these medications. So for this reason, we designed a pretty what I think was a straightforward intervention where you would tell the clinician, we randomized clinicians to getting an informational alert about their patient's characteristics that would be important for decision making about starting these medications, like ejection fraction, creatinine, potassium levels, blood pressure. And we showed the clinician what medications they were on, what medications they were not on, of the 4 pillars of GDMT, and then we made it easy for them to prescribe those medications in the outpatient setting at the time of order entry, which was what was based on the input we got from the clinicians. And we found that, we found a modest effect of this simple intervention. We had an increase in prescription of additional GDMT, and we also saw an increase in dosage, but and it reached statistical significance, obviously, and it was very exciting. But I think the bigger issue is what you alluded to. There is still massive gaps, right? So you're still, just based on the data for SGLT2 inhibitors, for example, that should be in the 80s and 90s, not in the 10 to 20%. So we have a long way to go. Right. This is just one. We were very excited about the fact that we made a small dent in this gap in terms of appropriate medical therapy for patients with HFrEF. But again, I think this needs to be a bigger conversation about how we can make this so that it's not something that, if you feel like doing it or you get prompted by an EHR alert, you do it, but you feel that there's absolutely no situation where we leave patients who qualify or who can tolerate these medications to be on these medications.
I'm just going to take a step back
Sure.
and talk about the methods. So you had this population of patients that were identified through your EMR, and you had all of the data points necessary for clinical decision making. You randomized clinicians to either EHR alerts or usual care, and you had about 93 clinicians randomized. Yes. Now, what did the alerts actually say? Did they highlight the medications that the patients were on and not on, or did they actually make recommendations for initiation of a class that may not have been part of the regimen?
So I'll give you an example for, so if Mr. Jones, who's 62 years old, comes to see their clinician, it would say, Mr. Jones, ejection fraction and so, potassium levels this, creatinine is this. Mr. Jones is on a beta blocker. It would say, carvedilol 6.25 twice a day, and it would say, he's on an Entresto at the dose, and it would say MRA none, SGLT2 inhibitor none, and then you would say, it would ask you if you want to click on the order set to maximize evidence-based therapies, and then only medications in the MRA class and the SGLT2 class would come up in that order set.
Right, and your primary outcome was the proportion of patients that had intensification of their regimen as measured by additional classes.
Additional class. So, if you went from a beta blocker and an ACE inhibitor to a beta blocker and an ARNI, it didn't count as a win. Yeah. If you went from beta blocker ACE to beta blocker ACE and SGLT2 inhibitor, that would be a win. So,
and what was the magnitude of benefit?
So the magnitude of benefit, depending on how you look at it, it was, I would say, almost a 40% increase in the proportion, and the number of patients needed to alert to get an additional class added was 14.
Right. What I found interesting was two things. First of all, among the patients or the clinicians that reported a benefit and perceived that these alerts were useful, only about 25% actually implemented change in response to these beneficial alerts. What do you make of that?
That's a really, really good question. Okay, so the people that we enrolled in the study, the clinicians, were the people who see most of these patients. So if I were to ask you, who are the clinicians who see most patients with heart failure with reduced ejection fraction within our health system, turned out that it's EP doctors, or EP doctors see a lot of heart failure patients. There were non-cardiologists who were seeing these patients. And I think, as Dr. Fonarow pointed out, like, they may say, oh, this is cool, like, they should be on this additional medication, but it's not my job, Right. And I think that sense of ownership is something that we are still sorting out, because they might say, oh, he's got a heart failure doctor and that guy's going to take care of it. So it's a question of, like, who's going to take responsibility for that patient during that visit, because the next visit may be 2 months from now, right? So we're going to look into that to figure out, like, who are those people who were making the changes? Who are the people who might have said this is really helpful but not have made that change? Or maybe they said, oh, this patient's stable, they haven't been hospitalized. Like, it's interesting that we can add this stuff, but we don't need to. So I think that sense of kind of, you should do something versus, like, you can do it if you feel like it, is still something we need to overcome.
The sense of urgency is not universal. And I think that because the follow-up period, even for event-driven trials, has been a matter of years, people don't perceive there to be any short-term benefit. Were the number of visits per group the same in your intervention and usual
I would have to look at the manuscript for that, but I can get back to you about that. Yeah, it is online at Jack.
Get back to me.
Yes.
Gregg, I wonder if you could weigh in on the implications of this trial that used EHR alerts, a simple intervention at the point of care to try to intensify therapies. Do you think this will help with the uptake of the new guidelines? Because we've certainly had no shortage of evidence, no shortage of tools to implement evidence, but certainly gaps. Do you think that this might be a way to fill some of those gaps?
So I certainly do. Tariq and his team have designed something that, is scalable and sustainable, right? So every health system is utilizing EHRs. These are rather straightforward programming. And so that ability to scale that up a country, and even with modest improvements, the implication for patients, just because we're talking millions with heart failure with reduced EF, is profound. But as Tariq acknowledged, this is one step. We clearly will need to layer on additional interventions that can get the treatment rates up even higher, provide additional motivation. I was struck in the data that it appeared as if the non-cardiologists, even though there wasn't a significant interaction p-value, seemed to be a little less responsive to the intervention. So it'll be important to understand, is this just going to align with cardiologists or heart failure cardiologists, or do we need something a little stronger in the push department for a broader group of clinicians? But I think this is, a really excellent step that could be then further built upon. I think it will be important, though, to study whether there actually is alert fatigue, that over time, this was a rather 6-month kind of duration study, whether this can be sustained or whether there's actually a virtual cycle where actually the alerts become more effective over time, where clinicians get in the habit of really thinking about each of these medications and trying to start, such highly effective, rapidly acting therapy with a greater sense of urgency. So I think this is a fantastic beginning of, using really electronic clinical decision support at the point of care to make a meaningful impact.
Those are the important comments, and certainly the endpoint was measured at 30 days. It'd be nicer to see some of the longer term outcomes.
Absolutely, we're going to be looking at that.
An intensification of the gap between the treatment groups, or if perhaps they merge and come together. Let me congratulate you on yet another trial that was executed incredibly well, a pragmatic trial done within your healthcare system that demonstrated that EHR alerts improve the uptake of guideline-directed medical therapy as measured by the proportion of patients on incremental classes of therapy within 30 days of the intervention. Congratulations to you.
Thank you, Harriette. And it's I really thank the patients in this study who've that we have such a long way to go, and there's so much work to be done. So thank you so much for highlighting this.
My pleasure. Thank you, Gregg, for joining us.
My pleasure.